Hi, I'm Dan Joyce. I'm a urologic oncologist at Vanderbilt University, and I'm here with Dr. Phillip Pierorazio from Penn, where he runs the Delayed Intervention and Surveillance for Small Renal Masses Registry. First of all, thank you so much for being here and chatting with us.
Thanks very much for having me.
Talk to me a little bit about active surveillance. Is it underutilized? And if so, why do you think so?
Yeah, I think it is still underutilized. If you look at the national statistics, only about 20 to 30% of eligible patients who are for active surveillance are actually undergoing active surveillance. It shouldn't be 100%, acknowledging that, but it should probably be higher than 20 or 30%. And it's just taken many years for people to feel comfortable with that kind of program.
So what are the things you look for that tell you, okay, this patient definitely qualifies for active surveillance and I need to talk with them about that?
Yeah, I think the first thing we always look at is the tumor. And tumor size is the easiest place to start the conversation. We know with masses 2 centimeters or smaller, the risk of that, first of all, being a cancer and then being a cancer that could leave the kidney is almost negligible. So we know it's safe to watch 2 centimeter or smaller tumors in just about any patient. The next piece of the puzzle is obviously the patient. And depending on age, comorbidities, what their personal preferences are, we can watch tumors up to 3, 4, or even larger based on what their profile is and their preferences for treatment.
So what do you tell those patients in the 3 to 4 centimeter range? Because I know those are the ones for me when they come into my clinic, I feel the most nervous about because of that increased risk of it spreading outside the kidney.
Yeah, I think we've become a lot more comfortable and we understand that basically the risk of metastatic disease is negligible under 3 centimeters. It starts climbing somewhere in the range of 1 to 2% for a 4 centimeter tumor. And over 4 centimeters, it can really start dramatically increasing after that. So we typically tell people when it crosses over 3 centimeters, or if they present with a mass that's 3 centimeters, it's okay to watch this now. The chance of this spreading or causing problems is incredibly low. But the closer it gets to 4 centimeters, the closer we start getting to messing with your survival and the risk of a cancer spreading. And that's the brief part of the conversation.
So you have a really fascinating abstract being presented here talking about the role of renal mass biopsy in this setting. Can you tell us a little bit about that? And then I'll ask you the question that's in the abstract. How does renal mass biopsy modulate our management of these patients?
Yeah, there's 2 ways to think about biopsy in these patients. And the group from Toronto and some other groups around the world kind of believe in biopsy everybody up front. And we call that kind of a histology-based active surveillance. And they make the claim that by knowing the histology up front, that can help modulate your surveillance protocol. For a clear cell, you might follow them more closely than you would a chromophobe or a papillary tumor, and obviously a benign mass as well. We've taken a different strategy because we tend to be a little bit more pragmatic, thinking biopsy is really not mandatory or essential upfront for surveillance. We know that small masses in general are safe to watch. So we typically biopsy our masses that are growing. When they start growing, that's when we're really trying to distinguish, is this a high-grade cancer? Is it a low-grade cancer? Is this potentially an oncocytoma that's growing and mimicking a cancer? So that's where we find it most useful. Other places to consider biopsy: patients in whom you think you need to do a radical for a small tumor, you probably want to prove that that's a cancer. And any patient who wants to know what's growing in their kidney, we're happy to stick a needle in.
So that kind of brings me to my next question. What is that point where you're like, okay, active surveillance no longer good, we need to do something and treat?
Yeah, once again, it depends on the patient. And we for most patients now, we kind of set a criterion. So let's say you came in with a 2 centimeter mass. If that crossed over to really got to 3 centimeters with your long life expectancy, we know that active surveillance is not going to be a durable strategy in you. So we tell you, yeah, you don't need surgery tomorrow, but we should probably start thinking about this in the next 6 to 12 months because this is just going to continue to go and grow and potentially be more problematic.
Sure.
If you are 80 years old, it's a different cut point potentially.
Yeah.
And you might be more willing to accept the risks, the small risks of metastatic disease when there's real tangible, even though we're really good at surgery, right? We love doing partial nephrectomies, but they have risks. And if we can avoid those risks, that's a big thing, big win for some patients too.
Do you see kind of newer technology coming out, informing this area and guiding your practice in the future? Are you looking into any of the newer imaging technologies like sestamibi or CA9, and how are you using those in your practice?
Yeah, I certainly hope they change what we're doing, right? We need to evolve and get better. Right now, we use sestamibi sparingly. Typically, once again, in somebody who shows up with a biopsy that says oncocytic neoplasm, the ones that kind of look like they have that central scar will order a sestamibi, and they can be useful. But we just got to remember, sestamibi is to diagnose benign disease, not to rule out cancer. I think the CA9 radio tracers are fascinating, and I think that has a real opportunity to change what we're doing. It's a non-invasive test. It'd be similar to ordering a CAT scan or a PET scan, and then we'd know up front if we're dealing benign or malignant. And then we obviously have to have the same conversations. Is this going to grow? Is it not going to grow? I think that may be a real big game changer in the short term. More long term, I think it's going to come from the blood and the urine. Hopefully we have good molecular tests that show us not really cancer or not cancer. We can figure that out. It's the aggressiveness of the cancer and how our bodies are responding to those.
Yeah, I mean, I think patients really respond to the less is more approach, especially if it's not going to be a life-threatening thing for them. Newer imaging technology that doesn't involve a biopsy that's not benign either and has its own risks associated with it is going to be super important. So thanks so much for talking with us. Really appreciate it. Super helpful and informative.
Always great chatting with you.